So we are now at the end of this very attractive module, and I would like to summarize a little bit of some of the key messages that have been provided by our different speakers. So first, Professor Susanna Price discussed about the different aspects of shock and how to really try to have what are the different types of shock. And I would like to make some analogy, because we have indeed the hypovolemic, obstructive, and distributive shock, but perhaps we should think at a pump. And for having the pump functioning, we need to have the tank which is filled. And when the tank is not filled enough, this is hypovolemic shock. Then, of course, we have a problem of the pump itself. When the pump fails, this is not working good. And this is really the cardiologic shock. Then we have the pipes coming out of the pump itself. And then if we have some obstruction on the pipes, this will be, of course, the obstructive shock. And at the end, when we have a leaky pipe, then we have the distributive shock. We are providing too much fluids, blood volume to some areas, but not enough to some other areas. And this is a very good way to try to understand what is exactly the type of shock in our patients. Then, of course, we have to discuss the different way to assess at the bedside whether or not our patient has shock. And this is not very easy, because we have a few clinical signs, but these are very easy to use initially when our patient is conscious, but when our patient are sedated, we lose a little bit of some of these, and we probably mostly rely, on one hand, on the clinical signs, the skin perfusion, and again, the capillary fill time is one of the very important one, perhaps aided by the mottling scores and perhaps subjective assessment of temperature, skin temperature. And on the other hand, then we need, unfortunately, to rely on some biological marker. And for this, of course, looking at lactate is a crucial marker, because indeed, acidosis can be, pH can be affected by many ways, and acidosis in itself is not okay. But lactate is a very good marker. But remember that lactate is sharply rising in shock, but slowly decreasing. So it's a very good marker to identify shock. The response to therapy is okay, but we need to pay attention to the time decay, and this is sometimes more complicated. For the hemodynamic tools, then we discuss a little bit of the pulmonary artery catheter. We have also some non-invasive or less invasive tools. These are multiples. We do not have exactly the time here to discuss this, but these are very important. And in each department, it's important to have access to at least one of these tools to assess the cardiovascular function. Do not forget the echocardiography. Echo is really crucial. It helps to not only to identify the type of shock, but also to assess the cardiac function in any given type of shock to really properly manage our patients. Then at the end, of course, we discuss anthropic agents and vasopressors. And I think that it is very important to remember that we should individualize the therapy. We do not have a given recipe that we can apply in each patient, but we can indeed have some guidance that, yes, in most patients, adrenergic agents will be the first use, both for anthropic agents or for vasopressive agents. But we need to have some additional agents to use when the patient do not respond to this initial one, or do not tolerate, because indeed tolerance is also very important. And also remember that we should target the dose to have the minimal dose associated with the optimal hemodynamic effect. Then, of course, we have to move to some other very important aspect, which is the SOSD concept. And for this, it is not only valid, of course, for the fluids, but also for the vasopressors and other agents we use at the bedside. And for the fluids, the most important aspect is perhaps to begin with the salvage phase. And the salvage phase is really initially where you give some volume and you do not have the time to really assess the response of your patient. But then we have the O for the optimization. And this is really the crucial part when indeed you as a doctor have a key role to play in these conditions. And indeed, because you will have to assess the circulation with all the clinical signs, the hemodynamic tools we have to really say, yes, this patient may perhaps benefit from fluids. And then we have different ways. We can use the heart-lung interactions to try to predict the response to fluid. We can also use the passive leg raising test. And then, of course, when we have detected that our patient may respond to fluid, we still have to assess what are the risks to give fluids. And when we think that the benefit risk is in favor of giving fluids, then we perform the fluid challenge. Because we need indeed to identify whether indeed not only our patient adequately respond to fluid, but also tolerate the fluids. And this is why indeed the fluid challenge is the best way to give the volume in our patients. Of course, we still need to think at what will be the optimal amount, because we do it once, we do it twice, and then at sometimes maybe we have to switch to another therapy, not because the patient is not really responding, but at sometimes giving a lot of volume is perhaps not the best solution. Some other solution may be something to think at. Then, of course, during the stabilization phase, what we try to do is to minimize the complications. And this is very important. We need at that time to already pay attention to the fluid balance, because in many patients, giving volume at that stage will not be the best solution. And don't forget the D for de-escalation. It's very important at some point to help the patient to get rid of the volume that was given during the optimization, and that now is in excess in the body and need to be eliminated. And for this, giving diuretics is one of the solutions at that time. Then, of course, a very important aspect to remember in the management of shock is that we have always to do several things at the same time. We have to identify the type of shock, first to identify that our patient is in shock, then to identify what is the type of shock, and at the same time, very important, at the same time, we need to treat the hemodynamics by supporting the hemodynamics, by giving the inotropic agents, by giving the vasopressors, and by giving the volumes. And then we end up by the troubleshooting aspects that were covered by Professor Jean-Louis Thébault. And this was a very important part, because we often face this, but we do not know exactly how to best treat these patients. The new onset atrial fibrillation, something which is worrisome, because we have seen that in these patients. But the most important aspect is that we have two things to do. First, try to get rid of the precipitating factors when feasible. Of course, treating sepsis will take time, but sometimes correcting electrolytes that are disturbed is relatively easy to do. Then, of course, we have to do the therapy with either electrical cardioversion or drugs. But do not forget that always try to get rid of the precipitating factors, even when we have to give electrical shock, because we need indeed to rapidly stop the factors that will continue to stimulate the occurrence again and again of atrial fibrillation. Then Professor Thébault discussed the features of the clinical signs and trying to detect the low flow states. And this is a very important aspect, because indeed clinical signs are very useful when present to identify the low flow state. But unfortunately, we have to admit that in many patients, clinical signs are not enough. And then we need to rely on other signs. So some biological signs, again, can be helpful, but echocardiography, again, has a major role to play here to really try to assess the fact that cardiac output is not enough and cardiac function may be impaired. And echo, again, is not only useful to identify that VTI, the cardiac output, is low, but also what is the source or the cause of the low output state. And this, again, is very important for helping to guide the therapy. When the patient remained oliguric despite volume, this was a very, very important point to address. And as mentioned Jean-Louis Thébault, it is very important to think at, of course, some anatomic causes and that we need to rule this out. But the most important aspect when this is ruled out is to try to optimize the hemodynamics of our patient. And for this, we have really two things to do, and sometimes we have to do it at the same time. Optimize the mean arterial pressure and optimize the flow, the cardiac output that is indeed going to perfuse the kidney. And for this is something that again need to be individualized. Individualization of therapy is really the key element of our way to treat our patients, because the way I will treat the patient in bed 1 is not the same as the way I would treat the patient in bed 2. And to end up, when we discuss refractory hypertension, then we need again to pay attention to several factors. And as mentioned, please ensure that your patient do not need some more fluids, because sometimes, indeed, as mentioned, the situation evolves. Also, we need, of course, to look back at cardiac function. And there again, echocardiography is a key factor to look for our patient, because then we can discover that we may perhaps change our interpretations, do something else for this. And then, of course, discuss for what could be the alternative agents that we have to use. Is it steroids? Is it changing the vasopressor agent? Again, something very difficult. We do not have a very good recipe. We need to individualize therapy. And perhaps something very important, we need to test the system. We need to give something else. It works, that's perfect. It doesn't work, well, we have to think of something else, and then perhaps use a third agent or use steroids or whatever. But at least we need to have something to test. And again, assess the response of our patients, because we don't just give something and leave the room. We need to be at the bedside, see the response of our patient, and then try to really optimize their response to different agents, to try to optimize the doses of the agents, because again, remember what we have said before, each drug has a price to pay. And so we need to have the best hemodynamic effect with the least price to pay, using the less drug as possible, less volume as possible. And with this, I will end up here, and thank you all for your attention, and take care of your patients.